For example, active phase would be 600 to 800 calories, and patients may be transitioned to gradually increasing the intake depending on their weight. So the advantage to this is the rapid weight loss, which may be needed prior to a surgical procedure, such as bariatric surgery. However, there is concern with the difficulty in compliance, especially in the active or the small caloric phase, and possible slowing of the resting metabolic phase. So which of the following calorie goals are better? So this is an observational cohort study linked to commercial weight loss diets of 9,037 patients on their diet of choice. They were placed on 3 months on either the very low calorie diet, which is just a 500 kilocalorie liquid formula, or the low calorie diet, which is
This
1,200 to
meeting is being
1,500
recorded.
And
formula
behavioral
and
therapy.
food combination, and restricted normal food at 1,500 to 1.8 kcal. So weight loss was largest in the very low calorie group, followed by the low calorie group, and finally the restricted normal food, all of which showed reduction in body weight greater in those who had a higher BMI. After their selected diet, patients were placed on 9 months maintenance phase with exercise and dietary advice. Now let us look at the studies which compare the different diets. The A to Z weight loss study included 300 overweight and obese women comparing high protein, high carb, low fat, and low carb. The highest weight loss after 12 months was with the low carbohydrate diet, although it was only modest at a mean of 4.7 kilos from the baseline after 1 year. Here is another study comparing the different diets, and all four diets resulted in modest weight loss in 1 year, with no significant difference between diets. However, there was an observed strong curvilinear association between self-reported dietary adherence and weight loss. Participants in the top tertile of adherence lost 7% of body weight on average. So this has always been the message of many weight management recommendations: adherence. So instead of the type of diet, let's talk about what goals will work for a patient. According to the American Association of Clinical Endocrinologists and American College of Endocrinology clinical practice guidelines, for those who are overweight and obese, uh, the treatment goal is to prevent progressive weight gain or weight loss in order to prevent development of weight-related complications through a healthy diet and exercise. For those who have metabolic syndrome and prediabetes, the goal is 10% weight loss for the prevention of the development of type 2 DM, although the benefit has been seen in studies even at just 5 to 7%. For those with type 2 DM, dyslipidemia, and hypertension, 5 to more than 15% has been seen to lower HbA1c, triglyceride, increase high-density lipoprotein, lower BP, and reduce medications. And for females with PCOS or infertility, 5 to more than 15% can help with ovulation, regularization of menses, hirsutism, and increased insulin sensitivity and pregnancy. So in fact, according to the available evidence, the guideline says that meal plans can include your Mediterranean, which increases intake of monounsaturated fat, fatty fish, less red meat, and the DASH or your dietary approaches to stop hypertension, which includes a low sodium, low saturated fat intake. So these two are scientifically proven and they are not fad diets. Meanwhile, depending on patient preference, they can go for a low carbohydrate, low fat, volumetric, or high volume or fiber and low calorie foods, high protein and vegetarian diets. Meal replacements and very low calorie diet is an option in selected patients and requires medical supervision. In addition to the individualized diet, aiming to reduce the total calorie intake, It should be something that they can do for a long term, not just for a week or a month. Self-monitoring can also help with adherence. And although the advice that we give in the clinic is important, but individualized counseling may be done by referring to a registered nutritionist dietitian to tailor the diet according to shared decision making, whether they will be provided a model or portion controlled food or calorie counting or food list or a meal pattern or menu so that they can comply and be well informed with their preferred diet. The patient should be coached over a series of visits. In some studies, the more frequent, the better. In summary, we have to be aware that fad diets come and go. It is important to guide our patients on the benefits, side effects, and alternatives. Let me end with this recommendation from the Obesity Medicine Association. The most appropriate nutritional therapy is one that is safe, effective, and the one that the patient will adhere to. But before we end, the Silver Symposium is brought to us by Abbott. Older adults who prefer a vegetarian diet may have greater odds of being underweight, of protein malnutrition, and having inadequate dietary intake. A solution to that is Ensure Gold Plant-Based, which is an oral nutrition supplement made of high-quality plant protein with soy, rice, and quinoa. It is complete and balanced with HMB for muscle, vitamins, and minerals, and it boasts a superior experience with its almond flavor. And with that, thank you very much for listening to this lecture.
Thank you very much, Dr. Joyce Bernardino Navarro, for that comprehensive lecture regarding different kinds of diet. So, I think we'll have lots of questions kasi ganyan na lecture ni Doktora. So, first question. We hear this on social media. What is dirty, strict, or lazy keto?
Thank you, Dr. Lima Akdal, my batchmate in the IM residency program. So, with regards, this is just to say that ketogenic diet, you hear patients that they succeed in the ketogenic diet or persons, but there are actually many different ways to do it. So some would do like strict keto, meaning they're monitoring their macronutrients, they're monitoring their actual intake with regards to the ratio, how little the glucose is, or how much fat they're taking in a day. The dirty keto is that they're allowing the intake of the processed food. So pwede sila mag-chicharon, maglongganisa, okay? So that's the dirty keto. And then the lazy keto is that they're just keeping the carbo low, and then they're just eating the fat and the protein that's allowed, but they're not really monitoring the calories. So maybe, of course, those who, for weight loss, caloric restriction is really the key. So maybe some patients who are on a ketogenic diet may not lose that much, and some patients on a ketogenic diet may have a side effect because they're not really eating. They're eating high in sodium or eating high in saturated fat. When the ketogenic diet is supposed to be high in your MCT, some plant-based fats, to have which is much better. Okay, so
Okay, so
thank you, Dr.
hindi
Ahmed.
lahat nakakita diet. Kung ako nag-improve, nabawasan ako ng weight, yung isa mababawasan din. Depende talaga siya. Okay. Second question, what is your comment about direct LDL and SDLDL? There is a certain doctor on Facebook who says elevate yung SDLDL niya.
All right. So noted on this, they say that the LDL, the density is larger, so it's not more atherogenic. So that's what those who are ketogenic say with regards to the LDL. However, it's very hard to tell because we know that the LDL is actually
This meeting is being recorded. This meeting is being recorded.
Coronary artery disease, peripheral, the type of LDL might be changed because they say that it has higher than yung fat globules niya, the type of LDL is not that atherogenic.
Okay. So next question from Dr. Aguilar. So do you recommend intermittent fasting for those who are doing 45 minutes to 1 hour HIIT
Intermittent fasting, they might not have enough power. They may not have enough energy or ATP in order to power through the HIIT workout. So it may be better if patients are
This meeting is being recorded.
actually 2 to 4 hours before exercise. And if at night, for example, the full meal at night, and then a light snack before the type of the exercise. Okay, so that would be usually what we would recommend. So they would be able to endure the exercise. So what other fat diets are advisable for those who are doing HIIT workout? So aside from the, of course, this increases your metabolic rate. Okay, so sometimes if the patients are very like sporty or vigorously exercising, then we can increase their caloric intake. What I would do would be I would review the patient's intake and I would review the weight pattern. For example, the patient this is the patient's diet pattern and this is the patient's exercise regimen and how it would affect the patient. So what would be the goal? Is it just muscle? Is it just because they want to improve their endurance for sports, for example, marathon? So it will depend. That would be the factors that I would look into in advising a diet. So the calories, the protein, the carbohydrate, and the fat ratio overall will depend on the activity and the profile of the patient. So thank you, Dr. Aguilar.
So better to have counseling diet first, nutritional counseling. So next question, what is your opinion on commercial plant-based foods sold in groceries, usually plant-based hot dogs, burger, tapa, etc.?
Yes, actually, it's much better if it's not processed because processing, of course, alters the quality of the food. There's different types of processing. So there's processing so that you can preserve the food, but there's also the ultra processed wherein you're adding in fat or sugar for the flavor and for the palatability. So my opinion on this, of course, everything in moderation. But of course, if you're aiming for health, maybe the whole foods plant-based diet might be better than relying on the commercialized or processed food. Thank you.
Thank you. Next question, what is your advice regarding feeding or nutritional build-up of patients in ICU or cancer patients?
Yes, so that's very challenging actually. So for our patients, ICU, patients who are at risk for malnutrition, we always start with nutritional screening. We check if the patient is at risk for malnutrition, and then we do an assessment. We check what are the causes that the patient has limited intake, and then we would, what is the profile of the patient, and then we would give the intervention, whether it's oral, enteral, or parenteral, so that we meet the nutrient requirements of these patients. So for ICU, of course, they have a they're very high risk for malnutrition. So they are very, especially those who are catabolic, those who have trauma, sepsis, and burns. Those are the highest in their
Intubated
metabolic.
patients.
Yes, intubated patients. And with cancer patients, we want to avoid cachexia. Okay, so thank you.
Next question from Dr. Dexter po. How do we make sure that the weight we lose is fat and not muscle protein?
Yes, I agree. So sometimes just looking on the weight on the scale might not be really reflective of the body composition. So of course, the ideal one would be your bioimpedance analysis, the ones that you see at the gym, where then they check for the fat percentage, the muscle percentage. But looking at our patients, we'll check for fat, like visceral fat here in the waist circumference. Yeah, and so that's where we check for our fatty deposits. And then for the muscles, the calf areas, the upper arm, so that would be the areas where you would want to check for the muscle, the firmness of the muscle. And sometimes patients who are going on a very fast weight loss are actually losing their muscle as well, and it's very soft. That's what we want to avoid. That's why it's not just diet, it should be diet and exercise.
Thank you. So another question, is Ensure Gold okay for diabetics?
Ensure Gold is a formula. It's a standard formula. So it has the carbohydrates, proteins, fats, and HMD. It's very good as a nutritional supplement for patients who are undernourished or at risk for malnutrition. So you give this to elderly, COPD, or even young individuals who are trying to gain weight. And for diabetics, they have another formula which has lower carbohydrate, and it has a lower glycemic index. So that's the Glucerna.
Okay. Sige. Last question. So any comment on the sustainability of weight loss from these diets? Weight loss is good to reduce obesity-related diseases, but what is the best way to sustain weight loss and avoid weight rebound or regain?
Yes. Remember that obesity is not an acute condition. It's something that needs to be managed on long period of time. So adherence is actually the key. They say that you have successful weight loss if you're able to lose weight between 5 to 10% and be able to keep it off over a year. So with regards to the sustainability, okay, so these diets, so number one, we need to select a diet that is suitable for our patient, one that is suited to their lifestyle. Baka naman vegetarian, hindi naman pala you're advocating for vegetarian pero hindi kumakain ng gulay, and then those who are not naman palatable sa kanila yung fat, then syempre they will not like a ketogenic diet. So it depends on the goal, okay, for the patient as well. So what's to avoid weight rebound and gain, number one, we try to avoid fad diets because these cause rapid weight loss and these will not be sustainable. So there in the consensus statements, you can do your ketogenic diet 1 to 2 years only, but after that you will need to transition. It's not something that's for life. Even your intermittent fasting, maybe it can be a way to simplify the caloric restriction, but it's not going to be a way of life for a very long period of time. It's just good for their initial loss. So what we would usually do for weight management, there are the 5 A's. So number one would be to ask, okay, ask your patient. So of course, patients need to be motivated. Do they want to lose weight? And then number two would be to assess the BMI. Do they have weight-related complications? As showed earlier, you have a higher goal for those who have metabolic syndrome or diabetes. It will benefit them, okay? And then next would be to advise. So this would be your advice for the patient. So remember, aside from diet, depending if the patient has weight-related complications, if you will assist the patient with pharmacotherapy, or if the patient is candidate for bariatric surgery, so for those who have a very high BMI, more than 40, or if they have weight-related complications. And then finally, you will next would be to agree with the patient. Baka naman you can start with one small goal per week. For example, limiting sugar sweetened beverages, limiting taking out, okay, or eating out, because those are very prone to increasing the calorie intake. And then finally, assist. Will the patient need referral to the dietitian? Will they need referral to physical therapy if they're having difficulty in mobility so that they're not able to exercise, and that's also a factor for their low metabolic rate. the low physical activity. So I hope that helps with your question.
Yes, thank you, thank you. So, dami question kay Doktora. Very interesting topic. So, with that, we end our Q&A for Dr. Bernardino Navarro's lecture. So, on behalf of De La Salle Department of Internal Medicine, thank you, Dr. Navarro, for sharing your knowledge and time with us.